We'll have discussion at the end. Next talk will be by myself on the importance of OCT in cataract surgery. Good morning, everyone. I'm Dr. Dhileesh P. Chandrasekharan. I'll be talking about the importance of OCT in cataract surgery. So, in the pre-OCT era, the armamentarium of the cataract surgeon to diagnose retinal diseases, macular diseases, consisted of fundus examination through slit lamp biomicroscopy and indirect ophthalmoscopy, and fundus photography, and investigations like ultrasonography and fluorescein angiography. So, these were relatively lacking, as you can see. So, certain lacunae was that this ophthalmoscopy is severely limited by media haze, and in elderly patients with tessellated fundi, there is total lack of contrast, and we are unable to pick up subtle macular pathology. So, this leads to erroneous treatment decisions. We may advise a premium IOL to a patient who has a macular pathology, and this can cause problems in the end. Patients can end up unsatisfied, and this will lead to litigations. And now even doctors get beaten for these kind of things. So these are mistakes which can be avoided with OCT. So B scan will be giving us information about position of the retina, but not about the function. Fundus fluorescein angiography is an invasive investigation, but it also can miss subtle changes like interface disorders, like Dr. Anubhav pointed out. OCT is a non-invasive investigation. It gives you very precise anatomical information about macular anatomy, and it and can also give you clues to the function of the macula. So for premium IOL surgeries, it is very necessary to confirm the macular integrity to avoid unpleasant post-operative surprises. So what to look out for? The things that are easily missed are your interface disorders. The VMT, epiretinal membrane and all are very difficult to diagnose through a hazy media, especially in a tessellated fundus. And dry AMD, wet AMD even can be picked up with hemorrhages, but dry AMD is very difficult to pick through a hazy media, especially in a tessellated background. Diabetic macular edema, old vascular occlusions where there are no fresh signs, just sclerosed vessels can be missed. Macular telangiectasia is the most common, one of the most commonly missed diagnoses, and pachychoroid pigment epitheliopathy is earlier we used to call it an old CSR. So these are the things that can be easily missed. So important thing is to trace the structures on the OCT of the patient. So mostly the outer layers have to be traced from one end of the OCT to the other, especially the external limiting membrane and the ellipsoid zone. So these layers, especially at the fovea and throughout the macula, have to be traced. Inner retinal layers may be less important; they also have to be traced from one end to the other. Several studies have evaluated the routine use of OCT for preoperative screening in cataract surgery, which excluded clinically abnormalized, they excluded. So there is a systematic review of 9 studies evaluating OCT as a preoperative screening tool. So the range of OCT detected macular pathology in this was ranged from 4.6% to as high as 26.4%. The mean was 13.7%. And the type of pathology detected was interface anomalies in 32% and macular degeneration in 42%. The largest study of this studied in this analyzed in this review was from Sudhalkar et al. This is from the Vasavada group in Gujarat. So they studied 1,400 eyes. It's a huge number, and their macular pathology detection rate was 9%, which is quite high. So in clinically, these were eyes which were determined to be clinically normal by the physician, and after OCT they found subtle macular pathology. So I'll come to some cases. This was a 65-year-old man referred for cataract surgery, BCV of 624 and 18. Clinically, through the hazy media, this was a tessellated fundus. We couldn't see much, but on OCT, we could pick up victromacular traction with almost an impending macular hole. He improved up to 6.9 and 6 with cataract surgery and vitrectomy. So this is a dense nuclear sclerosis with counting finger vision, counting finger 3 meters. We could see nothing through the clinically, but on the OCT we could see diabetic macular edema with a taut posterior hyaloid, So this patient was initially managed with injection and cataract surgery, along with cataract surgery, and she improved considerably. Even with that, she did not require a vitrectomy. And this is an old lady with the BCVA 618 N10, and she has a vitreomacular traction, but as Dr. Anubhav pointed out, this is just a focal VMT. Outer layers appear intact, so she may not need vitrectomy. She did well just with just IOL alone. So outer layers have to be clearly looked at. So coming to some post-operative surprises, this lady after a after phaco, she had a vision of 6/9 N10, and clinically we could see a little bit of parafoveal graying, and this is classical macular telangiectasia. And another patient, after one eye surgery, we were very happy, 6/6 N6. Other eye, when we looked at, we went ahead and did surgery, and on the tessellated fundus we could not see much, but she had an epiretinal membrane. So these are certain scenarios that can be avoided by preoperative OCT. There's another case where there are drusen, and there is, as you can see, some ellipsoid layer loss at the center of the fovea. So this is a poor prognostic factor. So, Swepsos OCT biometers these days have fixation scan. They detect the fovea through a Swepsos OCT. OCT. So they can sometimes pick up subtle macular pathologies, and the technician there sometimes refer the patient back to us, saying that there is something they can see. She needs an OCT. So this happens quite often these days. And when we go ahead and do the OCT, we pick up some vitreomacular traction. This was such a patient, and he underwent vitrectomy along with IOL, and he did well. So, but these are there is a study which studied the role of SSOCT biometers in detecting foveal pathology, and they said that abnormal SSOCT is a strong indicator of an abnormal macula with a high positive predictive value of 86%, but a normal macula on SSOCT biometer scan has a very low sensitivity and negative predictive value, so it cannot be used as a screening tool because it does not detect all macular pathology. So indirect ophthalmoscopy can pick up much more than your slit lamp biomicroscopy, especially in a hazy media. So it may not be OCT may not be considered routinely considering the cost, but visual loss disproportionate to the grade of cataract. Surely you have to do an OCT, and as a routine for all premium IOLs, also maybe you should consider an OCT. And for highly tessellated fundi where you cannot really make out foveal pathology, there also you should consider OCT. So in the pre-OCT era, macular surprises could be excused because there was no way to find them out. But now they are largely preventable because OCT is almost freely available these days, and especially in premium IOLs, it's very difficult to counsel the patient for a post-operative macular surprise. So it is less defensible medico-legally also. So these are certain things I wanted to highlight. Thank you.
Very nicely explained, Dr. Dhileesh. Thank you for the very nice talk. So this nowadays, most of us are documenting doing pre-op OCT, especially for premium IOLs, because post-op surprises are really difficult to counsel later on. And patients who are having a cataract vision loss out of proportion to cataract, it's better to do a OCT to see whether there is any problem sitting in the macula or not, because this can create problem later on after cataract surgery. Thank you.